quick case, so I don't know how it looks like. We'll try to make a video of it. Patient has abdominal aortic aneurysm, has basically endovascular graft, and then they had this surveillance every year. And then our surgeon usually do it without contrast. Let me just run it again. And this is one of the study as a surveillance. And then this is the axial view. I hope it shows okay. I try to change the window levels. Again, it's a non-con. And then if you compare to priors, and this is the prior CT. I'm sorry, let me just skip this one. And this is the prior CT, like 2019. Any concern?
I mean, it looks like the excluded sac has a lot of hyperdensity within it.
Yes. And then if I can stop it somehow. Sorry, there we go. Okay. So yes, that's, as you said, there's lots of density in the sac. And then if you look at this aorta here, that's a limb. That left limb is connect. And if you go on the other side, that's a right limb. And if you look at the prior one, it was like this. So basically it was type 3 endoleak, and it was pretty scary. And that's the, and that's actual. So the size was a little bit bigger, and then that's that disconnection. See, that's area. That, I don't know if it's a window level, show it. So I try to window it in a way that you can see it. And you can see the blood is kind of coming out.
Yeah. Did they end up getting a CTA after? Or?
Yes, yeah, they did CTA, and then they go to the OR, and it was type 3 endoleak. So they had to, they fixed it, they had to push back that limb to that stem.
Good catch. And over here, chest actually reads these, even if they're in the abdomen, they'll read all the vascular studies.
Oh, good for you.
You know?
So I never, personally, I usually look for the stent migration and also sac sizes. For this one, the sac was changed, but it just added to my checklist. And I also look for those, sometimes this limb, it just become disconnected and pretty subtle.
Ah, that was great. Are you presenting from your phone?
I'm presenting from my iPad. So yes, these are not actual packs. It's had a hard time to get these images. Basically what I did is just record it from the screen, and then I save it in my iPad. Hopefully it shows cool. Okay.
Yeah, it's great. Cool.
That's the only case that I have for today.
Thank you for sharing. I'm going to share my screen. Okay. Okay, so this first case is this patient. They've had a liver transplant about 10 years ago. You can see the liver looks pretty good. The findings were elsewhere in the abdomen. So if anyone sees anything, let me know.
Is it like omental caking and peritoneal implant everywhere?
Yeah, exactly. There's this huge omental cake, which kind of blends in with the fat here, but there's a huge omental cake. And then there's another finding on this image.
Small bowel looks thick also, Aarti.
Great.
Yeah, exactly. So this lupo-small bowel was thick and almost kind of had this dilated. Like, exactly, aneurysmal dilation.
So like PTLD with,
Yeah, exactly. So the patient had a liver transplant and then had this aneurysmal bowel dilation and omental caking. So we're thinking about lymphoma in the setting of PTLD. And just to show the corollary, this was the CT scan. So you can see that aneurysmal dilation. And then over there, the caking is like not as impressive, but you can definitely see it over here. It was just called ascites on the outside, but you know, we can definitely see the omental caking better. And then on this MR too, you can even see a little bit of restriction here. So anyway, they ended up, you can see how much it's restricting. So it goes along with lymphoma and also that bowel loop. Nicely, it has like beautiful restricted diffusion. So it goes along with lymphoma. So they ended up doing a small bowel enteroscopy and they went into the jejunum and it was like really ulcerated and abnormal, and they biopsied it here and it came back aggressive B-cell lymphoma with a monoclonal proliferation compatible with PTLD. So just a couple of points about PTLD. Bring it over here. You guys can see. So basically PTLD after liver transplant, about 90% of it is related to EBV infection. And it ranges from a reactive kind of lymphoproliferation, which is not yet lymphoma, to a high-grade monoclonal lymphoma. Basically because the immunosuppression suppresses the lymphocytes, the EBV kind of triggers the lymphocytes to start proliferating and become PTLD. The risk factors are if you have a seronegative recipient and a seropositive donor. This doesn't happen very often now, but it did happen in the past more. They try to now match these recipients and donors. And also if they're on higher dose immunosuppression, and it's the highest risk in the first year. Our patient was a little unusual. He was completely asymptomatic. He was, you know, on normal immunosuppression for about 10 years and then developed this acutely. The common immunosuppressants are this thing called MMF and also azathioprine, but most patients are on MMF. And somebody's asking, Victoria asked, why did they target the jejunum and not the omental mass? I'm not sure. Basically, we gave this report and by the next day they had the small bowel enterography, but we definitely do a mental mass biopsies frequently. So it seems it just got to the gastroenterologist first. And then when you have PTLD from liver transplant, the most common site is going to be in the liver. But then the second most is going to be systemic, including the small bowel, because the small bowel has a lot of B cells. And so the treatment is to stop the immunosuppression, especially if you are only in the phase where you have PTLD. But if you've progressed to lymphoma, then you would give chemotherapy. Any questions?
Nice case.
Yeah, we thought this is a really dramatic case. And then, yeah, we got the diagnosis was established pretty quickly. So now they're going to get chemotherapy. Okay, the next case is this one. This was a young female. You can see she has an IUD, she has a fibroid, and then she's got this kind of bilateral adnexal process. It looks kind of tubular on the right. Maybe there's like an abscess on the left and then another tubular structure. So we were concerned, yeah, Gitanjali got it. So we were concerned about bilateral tubo-ovarian abscesses. And there was a consult for a drain. And you can see that it's not a great, you know, there's a lot of vessels in the way here. You want to stay as close to the sacrum as possible to kind of stay away from your neurovascular bundles and your sciatic region. So anyway, our interventional colleagues ended up doing a ultrasound guided drain placement, and they went transrectal. And this is their post-transrectal. So you can see that the drain is going through the rectum right there, just went through the rectal wall and into the collection. And there's been significant decompression of like the midline collection with like decreased size of this other one over here. I'll just show you on the sagittals as well. So I was just asking them like, what, and actually it was pretty deep, but they were able to do this transrectally. So I was asking them about this, like, is it okay to go across the rectum? And they said, basically it's pretty much okay. Because it's draining in this direction, you're not usually getting translocation. And actually there's not even that much bacterial colonization of the rectum as it's like getting closer and closer to like the exit area. And the TOA probably has like a lot more multibacterial infection within it. And this is a lot more comfortable for patients than going percutaneously, transgluteally. And it also, it doesn't have the risk of vascular or neurovascular injury. So another way they could have gone as well is transvaginally. You basically just put a guide on your transvaginal probe or your transrectal probe, and then you can trocar directly into these collections. So I just thought that was cool. I have never done a transrectal drain. I think I would have been a little scared, but they did it and it was very successful. Okay, this is another case. This patient has, oops, I have some arrows there. Let me try to get rid of them. But anyway, they have symptomatic, I couldn't get rid of my arrows. They have symptomatic insulinoma. And what I thought was very impressive here was that there's this subtle little arterial enhancing thing here. So symptomatically, they have symptomatic hypoglycemia, and then they have this arterial enhancing thing that my colleague picked up. So it was a great pickup. You can't really see anything on the portal venous phase. And we essentially didn't see anything on the MRI. And that was resected because of their symptomatic hypoglycemia, and it turned out to be a grade 2 neuroendocrine tumor. So I guess like maybe there's some very subtle stuff here on the diffusion, but I found it very difficult to see on the MRI. So I guess one take, maybe it's here on the arterial phase, it really like blends in. But much more easily seen on the arterial phase of the CT. So if you have somebody who's symptomatic, look very, very carefully at the CT, even if it looks like not well-defined or, kind of lobulated. This was a neuroendocrine tumor that was like symptomatic. So I thought that was a good catch. And then.
Sorry, Aarti, I thought maybe the stomach a little bit thick, like it is seen with gastrinoma. I mean, it's collapsed. Is this anything in the gastrinoma? Had anything, or just insulinoma?
Their gastrin level was normal, and normally gastrinomas are more common in the gastrinoma triangle, so pancreatic head, duodenal wall, groove area. So I think this was just collapsed stomach, but that's a good point. Let me see how the stomach looked on the MR. And yeah, so in this patient, they very much clinically had an insulinoma. And then I think here, this is all normal rugae, just collapsed. Looks okay.
Did they bother with an endosonography and biopsy, or was it straight to the OR?
No, we kind of like were convinced enough about this. And so got a distal pancreatectomy. And I was actually very surprised that it was like a grade 2 neuroendocrine, because a lot of insulinomas are, benign, grade 1. And I think, if it weren't for the symptoms, I definitely might not have seen this, but yeah. And then my last case is an ultrasound. So I had to pull the images. So, okay. Well, anyway, you guys can see it here, right? So this is a patient who had neck swelling, and they had this ultrasound, and basically what we're seeing here is a pseudoaneurysm of the internal jugular vein. So this is the carotid, this was the internal jugular, this was the neck of the pseudo, I guess, I don't even know if, I guess this would be the very long neck, and then this is the pseudoaneurysm. So I hadn't seen an internal jugular pseudoaneurysm. I looked in the literature. This was a companion case from the literature. This was actually the picture of the patient. So she had a progressively enlarging bulge in her neck, pretty scary. They thought it was maybe a carotid pseudoaneurysm, but it turned out it was from the internal jugular vein. And the risk factors for these patients are basically, so I would talk to my IR colleague, like, would you do anything about this? Would you need to go? And he said, basically venous leaks usually tamponade themselves off. So they because they don't have high pressure flow, usually the surrounding tissues will tamponade it off. And as long as there's good inflow and outflow, then the jugular vein itself will not thrombose. So as long as like all the sinuses from the brain are still draining properly, hopefully this part will thrombose itself off and the jugular will stay open. They don't usually have to intervene on venous bleeds. The only thing is if there's a high pressure system. So in this patient, from the literature, she actually had tricuspid regurg. And so it was pushing a lot of pressure into her internal jugular. And that's what was causing the pseudoaneurysm. You can also get this like a venous bleed in your portal vein. If they end up lacerating it, can bleed, but usually only if there's really bad portal hypertension. So he basically said venous bleeds usually resolve themselves unless you have like a really high pressure system. Okay, that's it for me.
Thank you.
All right. I can show some.
Great.
All right, I'm going to try and see if I open to me. Okay. All right, so this is a patient with liver transplant who came in vomiting, and you can see that the patient has multiple hernias, and it was read as small bowel obstruction. So the surgeon called me from the OR and just said, just walk me through and figure out which one of these hernias is truly obstructing, because the patient had several. There was one here, there was something above. So and she also had bypass. So when I followed the bowel, you can see here, and then kind of, follow the bowel, it's, proximal jejunum is decompressed. And then all of a sudden you get into this kind of compressed area, and everything beyond that is markedly dilated. And then distally, this piece of hernia was the obstructing one. So based on coronals, you can see it nicely as well. So based on these images, I said that I am, here you can see, here's the proximal jejunum, and then just abruptly, you have this kind of beak-like appearance and everything is dilated. So I said, I think that there probably is an internal hernia, and then there's there's basically closed loop obstruction by the internal hernia and this inferior hernia here, and it was correct. So this is what they saw in the on surgery. All of this was all of these loops were an internal hernia, and it was closed loop obstruction.
Cool. And probably maybe those proximal loops were not dilated because she was like vomiting or something.
Right. Well, right. So usually, a lot of times in closed loop obstruction, the proximal loops are decompressed because of vomiting. She was vomiting a lot.
I keep on seeing what looks like a thrombus. Am I wrong?
Yeah, no, there was also SMV thrombus.
Okay.
I don't remember if it was related to anything, but there was an SMV thrombus right there.
Wait, was the SMV being pulled into the hernia?
See, I don't think so.
Oh, okay. It's just taking a little weird course.
Yeah.
Portion of the screen. Okay, so here, I'm taking that out. So from here on, you can remove the, okay. So this patient came in, she actually came in for a, for evaluation of her adenomyosis. They were looking, to either do embolization or something else. And incidentally, we saw that her liver was not normal. You can see here, there's just a piece of liver that has very abnormal appearance. All right, so annoying. I really don't know. Aarti, did you come up with a solution to this problem?
No, but I was thinking if you just show it through, like we could test it out showing through the virtual desktop instead. Like, do you guys have a virtual desktop?
No. And and it only happens here, so I don't know what's happening. Anyway, but here is the liver on ultrasound. You can see that the ultrasound liver has very, very abnormal appearance, just kind of heterogeneous. Now, patient had no history of anything liver related. Oh boy.
Looks like a diffuse liver disease, right? Not a focal stuff.
Right. So based on these images, based on this, we basically recommended MR for better assessment, and here is the MR.
The bones also look abnormal.
So here's the liver. Let me see if I can bring up the T2.
Gitanjali is saying HHT,
Which means
hereditary. It's like the Osler-Weber-Rendu
right. So
telangiectasia, hereditary telangiectasia.
right, so this actually excellent. This ended up being biopsied, and this ended up being hereditary telangiectasia. The patient actually ended up having a liver transplant, and the path, I've never seen this before. She basically had no normal liver. It was just all replaced by these, by these masses, which are like hemangiomatoid-like situation. So the interesting part is that she that's not like she was discovered incidentally, but after this she rapidly kind of deteriorated and then ended up requiring liver transplant because her liver function just went away. And again, you can see that there's on the imaging there's really no normal liver left, and based on path they saw really no normal liver. I've never seen that the path said 100% of liver parenchyma is replaced by by these.
But can you show the T2 again? And Gitanjali, can you tell us like what made you think HHT?
Yeah, I hope you can all hear me well. My speaker, I think it's not, mic is not that great. So I said it based off the arterial phase when you get these ill-defined areas of arterial phase enhancement. And we do a lot of, our IR section does a lot of these cases. So we get to image livers in those cases and it shows the similar findings. Yeah, this is a very typical appearance of small capillary telangiectasia in the liver. But if I had seen the delayed phases or the T2 fats at first, I wouldn't have guessed that. It was just based on the arterial phase and it has the appearances of those small capillary telangiectasia scattered throughout the liver.
I have a question.
Mhm.
Sorry. For those HHT, usually the hepatic artery is very dilated. Also, hepatic veins are very dilated. In this case, hepatic veins are very so narrowed. I was more toward a butt curie, some type of thing.
No, I mean the reason why everything was compressed is there was mass effect from the parenchyma, from just parenchyma being completely replaced by this process.
That's a really cool case.
Yeah. All right. Let's try again. Let's try for the next one. I'm sorry. I know this is super annoying, and I just can't figure out why it's just this computer specifically. Sorry. Okay. So this was a patient who has this mass in her. So this she had her CT for whatever reason. I don't remember what. It was an ED case, and you can see that there's like a polypoid mass which was extruding, prolapsing into the cervix. You can see it nicely on the.
Victoria, maybe just stop there and don't scroll too much so it doesn't freeze.
Okay, so here we go. So here, it's not the freeze. I don't know. It's just giving me some sort of exception error, which I don't understand what it is. But anyway, but you can see that there's this polypoid necrotic mass. You can see very nicely it rises from like this part of the endometrial, endometrial cavity goes down and extrudes inferiorly. On all,
Christina's saying prolapsed fibroid.
right, so prolapsed fibroid is of course the first thought. It's super necrotic, so we threw in some sort of polyp with cancer in it. So they did a hysterectomy. And any thoughts? I would have never guessed it. It was actually adenomyoma. It's a path.
So it's cystic adenomyosis.
It was just path-proven adenomyoma. And you can see that, there's like these low-level echoes in the leiomyoma, in this adenomyoma, sorry. So this, probably those hemorrhagic, spaces dilated, in retrospect. I don't think there's anything you can prospectively say other than what we thought, either prolapsing leiomyoma or some sort of necrotic polyp. But it was just a cool thing. There was just unusual path in this patient.
Victoria, in retrospect, like with that ultrasound, are we like the low level echoes is almost like mimicking an endometrioma?
I think so. I think that's like a chronic, you know how they get like these in adenomyosis, they get like these, chronic, hemorrhagic foci from dilated subendometrial glands. I think that's what we're looking at here, just kind of like blown out subendometrial gland. All right, let's see, let's try again. This is just a funny, this one is kind of like a funny case. This was a patient, bedbound patient. You can see there's perforation. I just want to draw your attention to this part of bowel and if, what do you guys think this may be? Let's see if I can. So here. I'm trying not to scroll too much.
Very thick and edematous. I'm thinking about lymphoma again, but it's pretty long segment. Doesn't look like adenocarcinoma.
Right.
Doesn't really look like ischemia.
Right. Okay. So then patient went to the OR and
Intramural hemorrhage.
Right. So all those correct, so all the things that you think about when we think about thickened bowel. Patient went to the OR and they did an X-ray of this. So just like you guys, I thought when I read this case a long time ago, I thought this was contrast in a very thickened bowel loop. But this was not. This was a foreign, but this was an ingested nylon sock coated with barium from CT done a few weeks before then. And so it mimicked, because it was sitting in kind of floating in between. Oh, great! Now the PACS decided to just freeze on me. Anyways, so this was the operating the patient, she perforated, and you can see here, right? So like in the retrospect, you can kind of see like, oh, I can see how this is a sock, just kind of bunching up on itself. But prospectively, this just looks like barium in a very thickened bowel.
Wait, so Victoria, you're saying that she perforated, the sock left her bowel, but also so actually when her sock was in the bowel, the contrast went into the sock kind of and got stuck in it.
Right. So she had a CT like a while before that, like 3 weeks before or something like that. So let me see if I can pull it up. Give me a second. Okay. So if we pull up the prior CT, I think that was it. So if you go back, this was like 3 weeks beforehand. You can actually go back and find this, or at least I was able to do that. You can find the foreign body here and figure out where it was. At least I thought I did when I was prepping the case. Here. So somewhere here I thought I could find it. Maybe not. Maybe I just was too excited about it that I thought I found it. Anyway, but there was some contrast administered beforehand, and that's what we think happened. This just contrast coded, because the contrast administered for this study did not reach this area. So this was coding the sock from the
Yeah, but it's coating the inside of the sock, which suggests to me that the contrast entered into the sock while the sock was still in her bowel. Which
no, it was, yeah, for sure. Yes.
That's cool.
That's just,
And Teresa wants to know whose sock it is.
I don't remember. This is a fairly old case. I just kind of started looking through my funny old files.
It's also kind of interesting that they took an X-ray of the foreign body. Did they normally do that? Or was it just for fun?
I don't remember. This is like 6 years ago. I just don't remember.
Victoria,
But
how come you
I have it in my note, ingested nylon sock coated with barium, mimicking small bowel wall thickening, cool correlation with an X-ray or something like that. So I don't remember. Based on the report, we actually read it as, thickened bowel, and I think that's why they operated it. We thought it was what do you call it? It was edematous and maybe ischemic, but I don't remember why they took the X-ray. So, okay, that's all I got.
Anyone else? Teresa, Ben, Nelly?
I could do okay.
I want to get it ready.
Okay.
Go for it, Steve. I
Steve
have
is
to get
going
my
to go,
case
and
ready.
then while Nelly prepares her case.
Okay. I did the same thing I did last time, which was search my follow-ups for follow-ups. And I found this case. It starts, I mean, this is a bit of a story. Starts with a prostate. This was already biopsied. Happened to be a Gleason 4+5, I think. We didn't need to, but it's a PIRADS 5, so there's restricted diffusion. Wait a minute. You guys can hear me, right?
Yes.
Okay.
Yes.
Here's the ADC map, and that's restricted diffusion. It's left posterior peripheral zone. I think this was done mainly for staging purposes. Here's the lesion here. He's got a background gland that's not very bright, so it's kind of hard to see the tumor on the T2s on the background of maybe prostatitis elsewhere, but you can sort of appreciate it here. Anyway, the glandular margin's fairly smooth. One of the things you're going to look for in these is, reasons why they wouldn't want to do surgery. And we didn't see one. It was pretty smooth margin, and I think he ended up having a robotic prostatectomy with a kind of a wider dissection around that left side, because that was the only lesion. Then, how much later? That was 8, 9, 10, 11, 4 months later, somewhere in between was surgery, but 4 months later, he was having some urinary symptoms, and so had a retrograde, and it looks like this on the retrograde. So this, we're thinking, urethra looks okay. There's a missing prostate. This looks like bladder up here, but then there's contrast getting into a cavity or a space. And I think this is, quite a little time after the prostatectomy. And this is suspected leak around the anastomosis or separation. And so subsequent to this, I think the same day, CT cystogram, which is this. On the axials, you can see the bladder here, and then usually you suspect it to be anastomosed to the urethra approximately here, but then there's like this cavity of contrast in between. Almost feels like where the seminal vesicles used to live. And then on the sagittal recon, it really looks like there's, you'd expect this bladder neck to be anastomosed down here to the urethra, and now instead we have this contained leak cavity in between.
It's so nicely contained. I wonder if it almost like it doesn't need to be fixed.
That's an interesting thing that you just said, because there's a propensity for the the urothelium to basically, re-urothelialize or endothelialize. And so if it's nicely contained like this, it's probably got a lining that's very stable. And so what all they did really was put a catheter in. They threaded the catheter up, and then they might have tried to fill the balloon up in the bladder part and pull it down and tamponade it a little bit. But there was a follow-up. This is about 3 weeks later, a follow-up CT cystogram, and the cavity is smaller. I mean, the bladder is a little bit lower. So they did achieve, I think, something in doing this. At one point, maybe the balloon was filled up in the bladder lumen and tugging it down and sort of closing down the space. But yeah, it was conservatively managed, and they never really did have to do a reoperation to reanastomose the bladder to the urethra. It's basically just this cavity that closed down. And the patient has done well. I think the PSA has remained low. So the decision to do the prostatectomy based on what the MRI show was appropriate.
Cool. We've had a couple of leaks like that, and especially if they have like a lymphocele that's splaying apart that anastomosis between their bladder and their membranous urethra. In which case, sometimes we have to put drains in the lymphocele, so it's not splaying apart that kind of delicate anastomosis. But we have had some leaks just like this. But ours were actually like not contained, and so they did have to go and fix them. But yeah, it seems like if it's already contained like that, it can just become an extension of the bladder.
Yeah, it was like part of the bladder.
Cool. Nelly, are you ready?
I'll go at the end.
This is the end, I think.
Oh, is it? Oh my goodness. Sorry, the images that I prepared, it's not loading, so I can't do it.
Christine has one.
Okay.
Yeah, we're buying you some more time, and we're going to see a great case from Christine.
Awesome.
Christine, where are you from?
She's probably muted.
We can't hear you, Christine, but you're up, and tell us where you're from.
Oh, sorry about that. I didn't realize I was muted. Can you hear me now?
Yes.
Hi. Yeah, I'm dialing in from Cornell. And let me just set this up so that you don't see the MRN or the patient's name. Okay.
I remember you. You're Manjul's fellow resident or colleague.
Yeah. Right. I was on one of these previously with Manjul. Okay, so I think. Okay, great. All right, I know I'm showing a brain, but there's a reason for it. So this is a 26-year-old guy with no prior medical history who basically showed up to the ER with acute onset antegrade amnesia. So he could remember everything that happened before the certain date, but nothing that happened after. So we start off with a brain MRI, and what you can see is that he's got these areas of T2 flare signal in the medial temporal lobes. So the working diagnosis at that time was some sort of paraneoplastic limbic encephalitis. And so he actually underwent an oncology workup, and his CT, chest, abdomen, and pelvis were all negative. So then we ended up doing a scrotal ultrasound. And the only thing that was notable was that in the right testis, there's this area, I don't know if you saw that on the cine, but there's like a hypoechoric area in the lower pole of the right testis. On certain views, it almost looked like it had pretty straight borders. It didn't have a lot of flow. So we were thinking either this could be some sort of infarct or, of course, an atypical appearance of a testicular tumor. And because the patient was deteriorating pretty rapidly clinically, they felt like they had to remove the testis. And so they did that, and the pathology came back as a burnt out germ cell tumor. And lucky for him, after orchiectomy, he was started on IVIG and steroids, and he actually got a lot better, just in terms of his mental status and memory. So just a cute case of paraneoplastic limbic encephalitis from a germ cell tumor in a guy. And
awesome.
yeah, and one thing I wanted to also just mention is that they ran a paraneoplastic antibody panel, and it did come back positive for this antibody called anti-MA2, which I guess is pretty common in someone like him. So male and with a testicular tumor. These patients often have this anti-MA2 antibody on the panel.
Wow, that's
We saw
amazing. So wait, you said that the chest and pelvis was negative, and so just to be complete, they went and did the scrotal ultrasound. They didn't, because this seems like it wouldn't even be palpable.
Exactly.
Wow.
So they were, really just fishing for anything at that point.
It's amazing.
But it was a hard call because it didn't, have like a typical appearance of a germ cell tumor, I would say. I mean, it just looks like the borders are kind of funky. But I mean, I guess it could be, he didn't have anything else going on, so.
Very cool.
What was the patient's age?
26.
26. So, I mean, that's a decent tumor type to go after if you're strongly suspecting a paraneoplastic syndrome.
Mm-hmm.
I might not have thought of it, but somebody did.
I have seen a couple of burnt out tumors that look like this, like where you get Mets in the retroperitoneum or chest,
Sure.
and then
Yep.
the primary tumor is burnt out like that. So beware the hypoechoic looking, almost dead looking mass.
Mm-hmm.
We had a case with patient. It was a woman, paraneoplastic. The patient also came in with encephalitis, and so they did like a full body workup to look for, there was a concern for paraneoplastic syndrome in the patient. So they were searching specifically for teratomas, like ovarian teratomas, and this patient turned out to have these little two bilateral tiny teratomas. That led to the NMDA encephalitis that the patient had. So maybe it's like a germ cell thing, This patient had seminoma, and then our patient had dermoids, causing that.
The NMDA receptor encephalitis thing is definitely known to be associated with dermoids. There's actually a really good book called Brain on Fire about a New Yorker young author who got it, and she actually was one of the first patients, and she got a brain biopsy at NYU, I think, and that's how they diagnosed the NMDA receptor encephalitis.
That's awesome. Okay, so should I present my case now?
Yes.
I hope this is going to share my screen. I'm working from my home workstation, so I'm hoping that this will work. Okay. I think you're going to be able to see my screen soon. You see my screen? Hello? I don't hear anybody.
Yeah, I can hear you.
We hear you.
Oh, okay. Sorry. Okay. So this is a patient who has a small renal lesion, and they were, it's been followed. This is a lesion here. It's enhances, and there's a washout. This is the T2, and then this one is it's the end phase. There was no like signal dropout, or nothing that was like definitely signal dropout. It's a small lesion. On the CT, let me I'm gonna pause it so I can drag my. Okay.
Could it be a lipid poor AML?
Yeah. So right, exactly. So we this is so this is a non-con CT, and we only have a non-con CT, but this was from a few years ago, and so it's stable in size, and sort of I hallucinated this like
Slightly
hyperdense,
more dense.
right?
Yeah.
I thought this was a dense lesion. Like we don't have the con, but we do have the post-con on the MR, and so we've been calling it, some RCC of some sort, and we suggested papillary because it was too dark. It enhances, kind of washed out. And then I saw the non-con, and I'm like, oh, but I think it's like I said what you said, right? I think it's a lipid poor AML because it's dense on non-con. So we don't have the path. The patient's on active surveillance, so we're not going to get the path. But I wanted to review sort of some of the mimics and differentiating features of lipid poor AML from clear cell or even papillary, right? Because they can be very similar on MR. So in this case, this was called papillary before, but I think the hyperdensity on non-con really helps. And multiple studies have shown that AMLs are dense, and they're more dense than any of the RCCs, clear cell, papillary, anything. So on average, lipid poor AMLs are about 40 Hounsfield unit, so a little bit more dense than clear cell in the study, and they're T2 dark. Clear cell are intermediate, and I think this is what fooled us previously, was that PAPs are also T2 dark, but unlike PETH, they're not hyperdense. Papillary are not classically intrinsically hyperdense.
Nelly, the other thing is papillaries don't usually have wash in, wash out. They're usually like low level progressive enhancement.
Yes, right, and it peaks on the nephrographic phase. So it's exactly. So in this study, when they compared to clear cell, like the enhancement pattern of PAPs, lipid poor AML, are similar to clear cell. So they enhance and they wash out. In contrast, like you said, papillary renal cell carcinoma, they're hypoenhancing on cortical medullary phase, and then they peak on nephrographic, but they never peak higher than the background cortex. So yeah, that was the other thing. So this thing didn't wash like a clear cell, but it was T2 dark and hyperdense on non-con, which made it probably more lipid poor AML than papillary and clear cell. And some can have a signal dropout depending on how much fat there is, but this one I didn't really definitely see a signal dropout on chemical shift imaging. So these are some of the things. So it's a key case that I wanted to share because it fooled us. It's been on active surveillance for 4 or 5 years, so it's not a big deal, but sort of nuances that I think are important. Okay, that was my case.
Cool. And I've heard now that Arkansas has an HHT clinic, and so they're gonna show us a case next time so that we can all remember this amazing HHT case that that Victoria showed us, and that we'll have some companion cases for. So if we ever see it in the future, we'll make the diagnosis.
Sorry, there was a Varsha. He said, could it be hemorrhagic cyst on non-con? Yeah, it could be hemorrhagic cyst if you just had the non-con, but we have the MR, which show that it enhances and washes out. So that and hemorrhagic cyst, we don't expect it to wash in and wash out.
Nelly, why do you think their AMLs are hyperdense? Is it because they're so densely packed?
I think it's because of the muscle component, no? That's what I think, but because you've got the fat, which is going to be hypo, and they're lipid. We only see that with lipid poor AMLs, right? That it's hyperdense. So I suspect it's the muscle component.
I think it's the M component.
Makes sense. Okay.
Cool.
Anyone else? Okay, have a good day.
Thanks, everyone.
Rupa says the sock is timely for Halloween.
Thank you, everyone.
That was the case of the day.
Bye.
Bye, everyone.